Well, good day, everybody. This is Chris, the Ancient Scholar. Hope this video finds you all doing well. In this particular video, I'd like to give my thoughts on the recently published trial known as ketamine or etomidate for tracheal intubation of critically ill adults, colloquially referred to as the RSI trial. This comes from authors Jonathan Casey et al. And I want to talk a little bit about it because I think it is important, and the results are, at least in my mind, a little interesting and certainly not what I would have anticipated. So this is a randomized trial conducted over multi-centers it involved about 14 emergency departments and intensive care units. This was in the United States. Where individuals were randomly assigned, or rather critically ill adults who were undergoing tracheal intubation were randomly assigned to either receive ketamine or etomidate for the induction prior to the intubation procedure. In addition to that, there were some dosing regimes that providers were able to select to include a low dose, an intermediate dose, and a high dose. And so when they looked at the intervention group, in this case was ketamine, comparing to etomidate, there were dosing options in the ketamine that ranged from 1 milligram per kilogram to 1.5 milligram per kilogram to the full or large dose, if you will, 2 milligram per kilogram IV push, which is a pretty hefty dose of ketamine, if I do say so myself. Although I think that dosing range lies within the official FDA dosing recommendations when you look ketamine up. But just from my personal practice, 2 milligram per kilogram boluses of ketamine's pretty hefty indeed. I'm certainly much more accustomed to doses, say in the 1 milligram per kilogram range when using ketamine as an induction agent. Etomidate was much the same. There were 3 dosing regimes for etomidate that could be chosen by clinicians, to include a high dose at 0.3 milligram per kilogram. This is a dose that I'm quite familiar with, and I used etomidate almost exclusively back when I was intubating on a regular basis when I was a flight nurse. And this was prior to a lot of the concern that was really pushed regarding septic shock. So we used etomidate almost exclusively for several years, and then it kind of fell out of favor with all of the concern about adrenal gland suppression, which is true, but there's never really a lot of robust evidence that this somehow would impact mortality, particularly in septic shock patients, although mechanistically you could at least surmise that there might be a signal if you actually looked at this. And I think this study here actually begins to answer some of those questions. So 0.3 milligram per kilogram IV push, an intermediate dose of etomidate 0.25 milligram per kilogram, and then a low dose of 0.2 milligrams per kilogram. Okay, so they took these patients. They were able to enroll 2,365 patients. Approximately half of those were in the ketamine group, and approximately half of those were in the etomidate group. Pretty well matched. They all involved adults 18 years of older who were critically ill. They did exclude trauma patients. It wasn't immediately clear to me why that was the case. I'm sure I could take a deep dive and figure maybe there was concern about head injury or something, but yeah. So mainly mainly critically ill patients. About half the patients had sepsis, severe sepsis, or septic shock. Average age of the patient involved in this was around 60 years old. So, pretty common to what you would commonly see in a lot of critically ill patients. So it was there were some outcomes. There was a primary outcome, and the primary outcome they looked at was in-hospital death by a month, or I believe it was 28-day mortality. And then this secondary outcome was what they defined as cardiovascular collapse. And there were a few criteria that would suffice for cardiovascular collapse. And cardiovascular collapse during the intubation procedure from the induction agent being given up until the 2 minutes following placement of the advanced airway device, which was endotracheal tubes in this case. They define this as a systolic blood pressure of less than 65 millimeters of mercury, a patient that required either a new vasopressor to support their blood pressure or increasing dose of their already established vasopressors, or cardiac arrest. In addition to that, this was not an outcome, but this was a signal that was found, and that is to say that there looks like there is a signal for ventricular tachycardia that was a little more common in the ketamine group. That's kind of interesting. So when we look at the primary outcome, death, 28-day mortality, there was really no statistical difference between the ketamine and the etomidate groups of patients. When we take a deep dive into the absolute numbers, you're looking at 28.1% in the ketamine group versus 29.1% in the etomidate group. But when we adjust and we look at it, you're looking at like a minus 0.8 points. The confidence interval from negative 4.5 to plus 2.9, the p-value of 0.65. What does that mean? There's really no statistical difference between the ketamine and the etomidate group. So that's not maybe super surprising, but this is what I found rather surprising, was an analysis of the secondary outcomes. Cardiovascular collapse, as defined by the criterion I've already mentioned, occurred 22.1% of the time in the ketamine group versus 17% of the time in the etomidate group. That's actually a fairly substantial signal. In most cases, this was in patients developing hypotension that required additional vasopressor support or new vasopressor support. And then in addition to that, I did mention this was not a pre-established secondary outcome, but this was something that was noticed during the study, and that is to say that ventricular tachycardia occurred more frequently in the ketamine group. Although the numbers were relatively small, it's still something very interesting to note nonetheless. So what are the take-home points, at least in terms of how I'm looking at the analysis of this study? Well, I think the take-home points take-home point is that this study, first of all, seemed to be pretty well done. It's pragmatic, but it's well done. These are sick patients. They're well matched. Yeah, I think some of the patients probably received larger doses of ketamine than perhaps I would personally administer. But that aside, I think that this does go against some of the common wisdom of people, where we tend to talk about ketamine and about how hemodynamically stable ketamine is. And I would retort by saying that any substantial induction agent is going to cause some degree of myocardial depression, including ketamine. But the thinking is that ketamine is traditionally associated with a catecholaminergic reaction or response, a catecholamine release in patients, and that can offset if not supplant, the hypotension that you see in other agents like propofol and whatnot. And so I think certainly in more contemporary times, there's been this big push to go towards ketamine, particularly in catechal patients where adrenal gland suppression may occur, like etomidate, or where hypotension may be a big concern, say if you're using propofol. And so certainly in the emergency and pre-hospital setting, ketamine is really dominates in a lot of areas, just because there's this preconceived notion that ketamine is probably better for blood pressure and probably doesn't cause hypotension to occur as much. And even though etomidate is a very hemodynamically stable agent, the risk of adrenal gland suppression has put a lot of people off. And looking at this study, it's very clear that the overall 28-day mortality is no different between the two agents. That said, it does seem reasonable to suspect that hypotension is a more commonly encountered situation when using ketamine when it's all said and done. And perhaps ventricular dysrhythmias may be a concern. And so this is rather interesting. This does kind of fly in the face of what maybe I expected, given all of the contemporary ideas that have been flying around the valence of ketamine, by how it's not only hemodynamically stable, but often associated with increases in blood pressure and increases in heart rate and so on and so forth. And that doesn't seem to pan out, at least in this study. And again, this is, yes, a pragmatic study, but it's a randomized controlled trial nonetheless. I think it's well done. I don't see any glaring issues. The precluding of trauma patients is kind of interesting. So perhaps there is some analysis or an argument to be made in the setting of trauma. But certainly in critically ill patients, the kinds of patients that are getting RSI day in and day out, I think it's reasonable to suspect that etomidate may become the preferred induction agent for a lot of people based on this trial. So that's kind of my overall impression. It seems well done, and the results, whilst I think the overall results were not super, I certainly anticipated that the overall mortality was probably going to be similar, all things considered, but I certainly did not see the hypotension as being a bigger issue with ketamine. So that's really interesting, and mechanistically that's interesting, and I couldn't even begin to opine on what mechanistically may be going on with the hypotension and with this possible signal of ventricular tachycardia. I think it's compelling, but yeah, I couldn't begin to imagine what the underlying physiology or pathophysiology of that may be. But there you all have it. That is my impression of this. I'm sure all of the other emergency and critical care talking heads have their own takes on this as well. I'd be curious to see what the MCRIT take is on this. But this is my take, and hopefully you found it interesting or compelling. And if not, I'm sure there's a lot of other takes out there that you can take a look at, other than mine. All right, everyone. Thank you so much. Hopefully you enjoyed this video. We'll see you in the next one.